Can you hear me okay?
No.
It's not working.
If it comes to it, we're real shouters. We're good at that, so thank you. How's that sounding now?
Not at all.
Not at all.
You might have to talk like this.
Okay, right. So, hi everybody. My name is Alexis Crabtree. I'm a resident physician in public health, and I'm currently at the BC Centre for Disease Control doing a postdoctoral fellowship there. My background in this area is through being a researcher with an interest in community-based research. And I traveled around the province with people who are actively using substances, looking at what were their health and harm reduction needs in different communities. So that's kind of how I came to this piece of here. Let me turn it over to Anne.
She says that's so common. It was fear and loathing in a car with, anyway, sorry, I shouldn't laugh. We did research, she says, it's okay, I'm sure. I'm sorry, I got the giggles. I don't know how she does this. She nerdifies being in a car with all these active addicts camping the whole way because her grandma gave her the car and she had $9,000. Like, who does this? Anyway, so she's very special. So I'm in Livingston, and I started a whole bunch of drug user groups. And so my research, we call it research in people life. I'm sorry, my interest is in having people who are people who use drugs create networks of support, and in the determinants of health you have, how income, as if anyone could find that, housing, if anyone could find that, and then of course the next one down is informal networks of support. So that's my absolute passion is you can't do anything else, and they can all make friends with each other and form networks of support, which may not look legal to anyone else who sees them. They are the life-saving initiative I'd like to see rolled out in this public health emergency. So I'm 63 now. We went through this whole overdose crisis in the 90s, so it's my second time around, and I'm a lot more grouchier this time. Just saying.
So here's what we're going to do with our time together. I'm going to go through some formal definitions of different terms related to stigma, and Anne's going to talk about what that means and what we see on the ground and how those play out. And then we're going to go into an activity and have a chance to reflect together on hopefully using those terms to talk about ourselves and our personal journeys. We'll come back and we'll see how the time is going and have a quick discussion about the impacts of stigma and some strategies for challenging stigma personally and professionally. And then we're just going to make sure we have enough time at the end to talk about stigma in rural communities. And I think this is as much a chance for all of you to educate me as it is for me to say anything and for Anne to say anything. So I'm going to talk about what the literature says really briefly, and then I want to have a discussion about what does stigma against people who use drugs look like here and what can be done to challenge it. So as far as terms, the first term I want to talk about is stigma itself. And I define this as negative judgments directed towards a person who is marked in some way. So the word stigma, you may have heard stigmata if you're from the Christian tradition, the marks of Christ on the hands. Stigma means mark. And what we know about stigma is that it's directed towards people who have a mark, so that people can have two responses. If they're visibly marked and they can't hide it, then they experience stigma in one way. They experience it directly directed towards them, and it's different depending on all the other marks that someone carries. So people who are poor experience it differently. People who are Indigenous experience that differently. So much so that sometimes people who are Indigenous are marked as people who use drugs even when they're not using substances. And then there's another group, which is people who can hide that mark in some way. And their experience of stigma is different. They hear it directed towards other people, and they know that if they are outed, that will be directed towards them. So their experience of stigma is about trying to hide it so that they don't experience those negative judgments directly.
Oh my gosh, right off on this one.
So I don't know if anyone follows the media with magazines like Thinks anyway, they're from the States. A woman named Maya Salvitz has written a really interesting and terrifying piece on how within a big hospital, either in Boston or New York, they would write SPOS, which means subhuman piece of shit. And she found out that this had been going on for quite many decades, and it's passed from one physician working in Emerge to another physician working in Emerge. And it's a really, it would be hidden. I mean, we wouldn't necessarily know what's going on, other than one of the medical students said that they were naively being very kind to a person who came in who may have been drug seeking or may not had abscesses, you know, and I don't think this will surprise anyone in the room to understand that people would be in Emerge who are quite severely addicted and in very poor health. And he was mocked and laughed at by the other physicians because he was being so kind and very engaging with this guy, and you know, you could go here or there, and you know, and they were kind of quite cynical, saying he's a waste of your time. And then he found out that, and of course the guy was back within a few weeks again, and had, of course, we're going to talk about that, many other barriers out there in terms of accessing treatment or whatever it was. So the shocking part of the story was that this kind of thing had gone on for such a long time without anyone really saying anything about it. And I think we think of physicians especially as not necessarily being that poorly behaved. It depends on your impression of physicians. But just saying, this kind of, it's just, you couldn't exaggerate just how terrible that behavior is, and yet that person is key to whether someone's really going to get treatment or not in a facility that many of us think of as an accessible place to get health care. So I just wanted to, that was the example.
So the next term I wanted to bring up is discrimination, and I've defined here as negative actions that flow from stigma. And Anne's going to speak to a little bit about how, so discrimination is how stigma takes effect and what it actually does to people. So Anne's going to talk a little bit about discrimination in terms of welfare.
So does anyone in this room help people with welfare forms? So in PPMB, regulations for PPMB, it says a person with a disability, comma, other than an addiction. So right into, and I don't know if anyone else has ever noticed this, we know because we work with Pivot and we're at VANDU, and some of the other groups have become quite radical in terms of saying when they spot this kind of thing, they try to get a lawyer and somehow get into court with it. It's tough. But it's an irony that we have a ministry of mental health and substance use really running around with ads on TV. Who hasn't seen the ads on TV? Everyone's seen them? He's a brother and a friend, and she's a mother and a sister, and they're lovely ads and everything, but the irony is that right in our own government act and regs, our government documents, PPMB is persons with persistent multiple barriers, and you get a lousy 40 extra bucks a month. Is it that low? Something like that. And but you're not forced to constantly search for work, which is a huge problem for people who are not capable of constantly bringing back all these signatures to prove that they looked for work, and then you get the cutoff, and then you get a 3-week wait. Is anything I left out about this torturous process? Anyway, this is one of the real terrible places for stigma and discrimination. Because I just wanted to say in Ontario, someone took a case and got to how far up the ladder they had to go, and addiction is recognized as a disability in Ontario. We have not found the perfect addict who could live long enough and go to all the kind of, it would take probably almost 2 years in terms of they apply, they get turned down, you do the reconsideration, then you do the appeal, then you have to ask for a judicial review, and they're actually still alive, or you can find them, and get them all the way through this process. So we've got a very, that is a huge leftover from God knows what era, or maybe it's just reflecting what really is going on around us. I'm not sure. Some of us in harm reduction can kind of get off in a bubble and not realize just how despised drug users are. So that's an example I wanted everyone to be aware of. Whether we're going to get action on it or not, I think when you're doing the applications, it comes up on this document called the employment plan, which it violates people's charter, that employment plan, because it says all the way through it that you cannot appeal any of the decisions made about your employment plan. And it's not true, so keep pushing if anyone's doing these things. And I just wanted people to be aware of just how obvious that discrimination is against people. On the PPMD form that one of our, Laura Shaver showed it to me, she's the president of the BC Association of People on Methadone, and they had, anyway, and on it says that she can be kicked off welfare for not seeking every remedy to her addiction. You've seen one of these. And I said to you, we're trying to send this back and we're sending it to the the Overdose Emergency Resource Center. Everyone's working away to stop these overdoses, and then we've got this blatant kind of problem going on right in the middle of things. If, as people say, did she get cut off? But she could. And this is the kind of sometimes punishing treatment you'll see. Someone as lowly as some recovery house in Surrey, who has no qualifications to run a recovery house, can simply call and say that they thought they were high or whatever, they booted them out, and they can be cut off welfare, and then they've got this awful consequence of a 3-week wait and trying to reapply for things. So I just wanted everyone to be aware of the kind of blatant discrimination we've got and squawk about it.
So the next term I wanted to introduce was internalized stigma or internalized shame. And this is negative feelings that are directed inward as a result of stigma and discrimination that people face in society.
Oh. So many years ago we started VANDU, and at the beginning we would have these discussions. This is about 1998. We had a huge overdose crisis. I don't know if it was up here or anyone was old enough to remember it. And we had a massive outbreak of HIV. And when a member of your group says, I never got a beating from the police I didn't deserve, I actually, you realize there's not much you can say, because this is someone who's been arrested and rearrested and rearrested, and they